and his searching was beyond organ-specific disease, rather more focused on giving a better functionality and quality of life. So let's start. Smita.
Good afternoon, everybody. I will be presenting the case. The patient was 61-year-old female, presented with us with a chief complaint of backache for 3 months, difficulty in walking from 2.5 months, and loss of sensation in bilateral lower limb for 2.5 months. History of presenting illness. Backache was present in dorsolateral region. It was insidious in onset and gradually progressive. It increased with activity and decreased with rest. It was continuous and it relieved with medication, and there was no diarrheal integration. Difficulty in walking. Weakness was insidious in onset and gradually progressive. First patient was able to walk with the help of one stick. Then she could walk with the help of a walker. Then patient became bedridden. Loss of sensation in bilateral lower limb. It was associated with history of cotton wool sensation in bone beat, along with history of tingling and numbness sensation in lower fat. There was no history of bowel bladder involvement. There was no history of fever or chronic generalized body ache. No history of oral steroid intake or stress fracture. There was no history of diabetes or hypertension. There was no history of waxing weaning of symptom, arthralgia, myalgia, dry mouth or dry eye. In past history, there was no history of TB, malignancy or trauma. In personal history, patient was vegetarian without any addiction. Sleep was not affected, appetite was normal, and bowel habits were regular. In examinations, vital were stable and patient was afebrile. General physical examination was within normal limit, and thyroid and breast examination shows no palpable line. In local site examination, tenderness was present at beaten vertebra. There was no bony deformity, gibbous, scoliosis or kyphosis. There was no erythema or bump was present on palpation. In CNS examination, higher mental function and cranial nerve examination was normal. In motor examination, bulk was normal in bilateral upper and lower limb. Tone was normal in upper limb, and in lower limb, bilateral spasticity was present. In power, in upper limb, in all joints, power were 5/5. In lower limb, in hip joint, bilateral power was 1/5. In right ankle and knee, power was 1/5. In left ankle and knee, power was 2/5. And in extensor hallucis longus, power was 0/5 bilateral. In reflexes, in biceps, triceps and supinator reflexes were 2+. In knee and ankle it was 4+, along with clonus was present. Bilateral plantar was up. In sensory examination, all sensation was lost below T12 sensory level. Cerebral examination was normal, and gait and balance could not be assessed. In systemic examination, other systemic examination was within normal. So, on the basis of history and examination, primary clinical diagnosis of extradural compressive myelopathy at sensory level T12 L1 and bony level of T10 T11 was made, with probable etiology of quad spine, metastasis or degenerative. In investigation, routine investigation was within normal limit. So MRI dorsal spine with screening of whole spine was done. Now I like to invite Dr. Jagdish from radiology department to explain the MRI finding of the patient.
Good afternoon. We have a MRI post-spinal patient. Their stir side images. On stir side image, we can see the compression collapse of the D11 vertebra with altered soft tissue involving the D10, D11, D12 vertebra, and also the involvement of the posterior elements. There is extension of the soft tissue into the spinal component, causing the compression and narrowing of the spinal canal with compression of the cord. If we can move over here nicely, there is narrowing of the spinal canal with compression of the cord at this level. These are T2 side images. We can see there is the altered in soft tissue involving the body, posterior elements, as well as paraspinal muscles with intraspinal extension causing narrowing canal and compression of cord at this level. They also pre-vertebral paravertebral soft tissue also seen. Here are T1 vertebral side images. The soft tissue is hypotense on T1 vertebral images. They are post-contrast images. There is arterial enhancement of the soft tissue. So, based on the imaging finding, our first possibility is vertebral metastasis, and differential include the primary vertebral tumor, plasmacytoma, or atypical hemangioma.
So from history examination and MRI finding, pot spine was ruled out and following differential were made, either it's a metastasis or primary bone tumor. So we did a USG guided biopsy to confirm the diagnosis. While biopsy report was awaited, we kept these 5 differentials in our mind, considering the age and sex of the patient and worked up for them. In breast, there was no palpable mass or axillary lymph node. Mammography was normal. In lung, there was clinically no lung mass. CECT chest was normal. In renal, CECT abdo shows no sign of malignancy in kidneys. In thyroid, there was no palpable mass. Ultrasound neck shows benign lesion. FNAC from neck shows no evidence of malignancy. And in bone tumor, biopsy report was awaited. So biopsy report came which was immunopositive for TTF1 while negative for ER and PR, and feature was suggestive of metastatic adenocarcinoma, and patient was suggested to work up for lung primary. So after that 18 FDG whole body PET CT was done, which shows metabolic active lytic destructive lesion involving D10 and D12 vertebra, probably metastasis, and hypodense lesion in both lobe of thyroid with mild FDG uptake was present with speck of calcification in right ear. So as PET scan was showing mild uptake in thyroid, we worked up for thyroid malignancy in detail. Ultrasound thyroid shows sign of benign lesion, and ultrasound guided FNAC was done, which shows no evidence of cancer in specimen, and thyroid function test was within normal limit. So our workup at this point revealed no site of primary. It left us with the following possibility: either it's a carcinoma of unknown primary, or it's an occult thyroid carcinoma which was causing paraplegia, or it's an occult lung carcinoma. So points in the favor of occult lung carcinoma was it was more common and its TTF1 was positive, and points against it was CECT chest was normal and PET CT shows no uptake in lung. And point in favor of occult thyroid carcinoma was that PET was showing uptake and TTF1 was positive, and point against it was that there was no thyroid mass clinically. Ultrasound thyroid show only benign lesion, and FNAC, ultrasound guided FNAC from thyroid shows no evidence of malignancy. While we were facing diagnostic dilemma, we also had a therapeutic dilemma, whether to do surgery or palliation. For decision between surgery versus palliation, modified Tokuhashi score is used. For a score of equal to or more than 9, surgery is preferred. In view of gradual neurological deterioration, despite a score of 7, we preferred proactive surgical intervention. Now I will like to invite Dr. Manoj Falak to explain the series of events which took place during neurosurgical intervention.
So this lady came to us with a history of paraplegia. By the time we assessed this patient was paraplegic and was having bladder wall involvement. So this is the CT scan of this patient, and as described by the radiology people, this patient had a lytic vertebral lesion which was involving the transverse process of the D11 as well as the rib head which articulates there. Also a part of D10 vertebra and D11 vertebra posterior superiorly were involved. And on this sagittal CT, we can see that the normal thoracolumbar junction has become deformed due to this destructive lytic lesion activity. So this is the tumor focus which we thought that has patient presented with, and it has caused spinal canal narrowing as well. So the planning in surgery was, the factors considered were clinical, the clinical status of the patient, the KPS, then spinal instability neoplastic score, Tomita score, and Winston-Boriani classification. So the spinal neoplastic score says that, patient who present with more than a score of 7 in any specialty, they should be considered for surgical consultation. While the scores between 0 to 6 are stable, and 13 to 18 indicates instability and must be operated on. So this patient had a score of 14 in this case. And the Tomita score, which is based on primary tumor visceral metastasis and bony metastasis. I'm sorry, this red markers are a bit off due to the slides being rearranged. So this patient had a Tomita score of 6 because the patient had an unknown primary and the patient had no visceral metastasis and multiple metastasis. So according to the clinical presentation of this patient as well as the radiological evaluation, this is the Winston classification which visualizes the vertebral body as a clock from 1 to 12, and the surgical approaches are decided according to this. We can perform a sagittal corpectomy, unblock corpectomy, vertebrectomy with double approaches. So the surgical options were, one was the curettage, piecemeal resection, the other was marginal resection, and en bloc spondylectomy, and followed by reconstruction. So in this patient, since the thecal sac was encased by the tumor, so the option of en bloc spondylectomy was already gone, because once you violate the tumor margins, it no longer remains en bloc spondylectomy. So essentially the only option was curettage in this patient. So in view of unknown primary, a surgical plan was done in this patient despite a Tokuhashi score of being 7, and a posterior approach was planned with costovertebrectomy and tumor removal with stabilization, followed by an anterior approach if required. So the operative procedure was a midline incision. The exposure of tumor was done with healthy muscle cuff around the tumor so as not to violate the tumoral boundaries initially, and D9, D10, L1, 2, 3 pedicle screws were inserted in view of the junctional involvement. Temporary rods were inserted on one side, the unaffected side, and the rib of D11 was resected with the vertebra, taking a plane from the pleura, and circumferential dissection of tumor around the dura was done. Now that since we had to dissect dura around, so it became a piecemeal excision. And then we did a fixation under O-arm navigation. So this is the intraoperative picture. We exposed it from D9 till L3, and this is the tumor with healthy muscle cuff around, and this is the rib. This is the 10th rib, this is the 12th rib, and this is the involved 11th rib. So this is the O-arm machine under which we can navigate all the spinal pathologies, and we can pinpoint the location, what tumor and what parts we need to take out. So this was the pre-op imaging on O-arm, and it delineated the tumor very beautifully, and then we navigated these images. First we did an excision of this tumor, and we packed the cavity with some sponges initially for hemostasis with a thrombin matrix, and then we did a fixation of this patient as we planned for a reconstruction. The intraoperative impression was a highly vascular tumor, probably metastatic in origin. Intraoperative pleural tear was present, which was repaired primarily. The blood loss was 2400 ml, and patient required inotropic support intraoperatively, so the patient was shifted unreversed in ICU. The patient was extubated on post-operative day 2. Patient had some chest infiltrates and developed transudative effusion on left side, which was managed with tapping and conservatively, and the tone reduced by 30% on post-op day 1 itself. However, the power did not improve on day 1, and the patient was transferred to the primary treating specialty on post-op day 5 after stabilization. So I would like to call upon the pathology colleague SR Dr. Tripta to discuss.
First we received the core biopsy. The core biopsy which showed the tumor, and the tumor was arranged predominantly in glands, and as it has been previously said, for immunohistochemistry the cells were positive for TTF1 while they were negative for ER, to rule out the possibility of primary breast carcinoma, and based on the possibility of TTF1, the possibility of lung carcinoma is considered. Then followed this, we received the excision biopsy of this vertebral lesion, and it also shows the tumor which was arranged in glands as well as the focal papillary architecture and the glandular arrangement of the tumor. And the tumor cells have the moderate cytoplasm, and they have the round to ovoid nuclei with fine nuclear chromatin. On immunohistochemical stains, the cells were positive for CK7 while negative for CK20, and as previously the cells are positive for TTF1 and negative for P53 and WT1 to rule out a possibility of ovarian ovarian carcinoma as primary. So based on the TTF1 and CK7 immunopositivity, the possibilities considered were follicular variant of papillary thyroid carcinoma and adenocarcinoma of lung. To confirm the diagnosis, we did the immunostains for thyroglobulin, and the cells were diffusely immunopositive for thyroglobulin, with the thyroid primary is considered now. So followed this, we received the total thyroidectomy specimen, and it showed a small 6 mm nodule in the right lobe, and sections from that show a tumor. This is the normal thyroid and the tumor, which was arranged in back-to-back follicles with the areas of calcification, and the on higher magnification the cells have round to ovoid nuclei with prominent nuclear borders, nuclear clearing, as well as a groove. So these are the features of papillary carcinoma and the arrangement of the tumor cells. The diagnosis of follicular variant of papillary carcinoma with foci of calcification was given.
Since, as ma'am explained, the histopath, it was CK7 and TT1 positive, along with thyroglobin was positive. So that was suggesting of primary from thyroid. So thyroidectomy was planned, and total thyroidectomy was done by one of the most eminent thyroid surgeon of India, Dr. Sunil Chumbar from Surgery Unit 2. And patient was stable post-op, and thyroid specimen was sent for biopsy. Which ma'am explained, a tumor came with 6 into 5 into 3 millimeter, which are features suggesting of follicular variant of papillary carcinoma. And thyroid scan was done, which showed uptake at metastasis site. So radioiodine ablation was planned after 1 month. Now I will like to invite Dr. Arun to explain about the radioiodine ablation.
The left two images show the diagnostic whole body radioiodine scan done after 2 millicurie of iodine 131. The scan, this first image is the anterior and the next is the posterior image. Anterior image show mild uptake in the neck with the intense uptake noted in the thoracic vertebral region. The mild uptake in the neck is suggestive of very good excision of thyroid gland with very minimal tissue left there. The intense uptake is suggestive of the metastatic side. After the whole body radioiodine scan, diagnostic scan was done, 200 millicurie of iodine 131 was given for therapy. This is the post-therapy scan. After the therapy, as is seen in the posterior image, we see intense concentration of iodine 131 in the thoracic metastatic site.
Thank you, sir. Follow-up after 1 month, radioiodine was given, and patient was able to walk, and there was no complaint of pain. So final diagnosis of follicle variant of papillary thyroid carcinoma with vertebral metastasis was made. Now I will like to invite Dr. Gaurav from Geriatric Medicine to make us wiser with review of literature on this topic and take some critical questions.
Good afternoon. Now I'll give the review of literature on the topic. I'll attempt to provide a brief overview of two main topics. Number one being spinal meds, number two being the preoperative assessment of elderly. Coming to topic one, the spine happens to be the third most common site of metastasis in the body after the lung and the liver. 5 to 30% of patients with systemic cancer present with spinal metastasis, of whom 10% end up being symptomatic, and they largely present with epidural involvement. That is, almost 98% of the symptomatic patients have epidural involvement. So which are the common sites in the spine? 70% of the patients come with thoracic spine involvement, especially between T4 to T7. Of the remaining one-third, 20% come with cervical spine involvement and 10% with involvement of the lumbar spine. The primary sources of the spinal med, 2/3 of the patient come with primaries from the lung, breast and the GI tract. The remaining 1/3 is split between melanomas, thyroids, lymphomas, prostate and renal cancer, renal cell carcinoma. Coming to thyroid metastasis spine per se, it occurs in 2 to 13% of differentiated thyroid carcinomas, and the most common site of bony metastasis is the spine, where there is a predominance of red bone marrow. On imaging, they usually appear as osteolytic lesions, and these metastases tend to occur more in follicular carcinoma compared to papillary. So, how common is it? Coming back to point number 1. As previously mentioned, 2.5% of spinal metastases are from the thyroid. But on doing a case review, we found 11 case reports of occult thyroid carcinomas which presented with metastases to the spine. The age group varied between 27 to 60. We did not find any case report in the elderly. So that brings us to the reason. Why did we choose to present this case? The reasons are threefold. Number one, the rarity of diagnosis, as previously mentioned. Second, the age of diagnosis. This was a case which we found in an elderly patient. And the third was the quantum of improvement following an intervention. At this point, we had certain concerns and expectations, both from a medical viewpoint as well as from the patient viewpoint. Number one, from our viewpoint, was here was a pre-frail patient with an advanced malignancy. Was she fit to undergo 2 major surgeries? The other concern from the patient viewpoint was she had lost her complete independence. She was bedbound for over 3 months, and she had concern over a future action, both regarding the surgery as well as the complications of the surgery. So it put us in an unenviable situation wherein we either pursued a posture of masterly inactivity and let her resign to her fate, or we adopted a radical posture and attempted to restore her functionality. So when confronted with this situation, this scenario, doctors in the past largely tended to rely on their sense of intuition and experience to identify patients who would tolerate procedures and surgeries better. Unfortunately, age was one of those factors which intuition often got wrong. To succinctly put it, this is a famous statement by a judge in the Supreme Court, of the United States, where he mentioned, while I can see it, while I can't define it, I know when I see it. That is, he refers to his sense of intuition, which we all come across in our day-to-day life. So to lend some amount of objectivity to this subjective phenomena, certain scores have been used to predict outcomes in surgery, like the POSSUM score, the ASA, the BUPA score. Along with the usage of these scores, it's important to have implement other tools of assessment to look at the cognitive impairment, depression, the functionality of the patient before the operation, nutritional status, and very importantly, frailty. Now, what exactly is frailty? Frailty is something which we are all aware of, but something which we all know very little of. It's a term which identifies patients who have a diminished capacity to compensate effectively for external stressor. It basically puts them at a greater risk of adverse outcomes. So adding frailty to this risk assessment will help to increase the predictive power and help to screen patients better. So as this case was nearing its logical end, we were presenting another case in the ward. Again, a 62-year-old female who again came to with spastic paraparesis, found to have a lesion at L1. The biopsy was, which again revealed a follicular variant, again a papillary carcinoma of the thyroid. She again underwent a total thyroidectomy along with spinal surgery. So the take-home message, the point which I am trying to make across is strong intuition and stubborn persistence. These are two very important virtues which are keys to solving diagnostic dilemmas. So important that the initial level of the patient was that, and later post-intervention the patient's condition is this. Now I request Dr. Prasoon to take center stage and give the final word.
Thanks to all for listening us, and thanks to all the multidisciplinary team who helped us in this process. I was just wondering, who can explain happiness better than this lady who came to us with paraplegia with a lot of hope that AIMS will do something for me, who has a burden in her family to take care of her demented husband. In between, she came to know that she has something which is tumor or cancer, which will be treatable or not treatable, I don't know. Then, of course, as in the course we have mentioned, that persistence of our junior resident and extreme level of cooperation from multiple disciplines like neurosurgery, thyroid surgery department, pathology, radiology, and nuclear medicine. So we are thankful to everybody, and of course, I think patient is very happy with this outcome. So I request if anybody has a question, and before that, I'll say if Professor Kale wants to say a few words.
It's a rare diagnosis. thyroid metastasis to the spine, very rare. Like somebody said, 11 case reports only. So I would have never thought of it as a primary from the thyroid. All I can say is we just worked as an unknown metastasis, unknown primary. And the good thing about extradural metastasis is that if you remove the compression, there are high chances of molecularity improvement. If it's an intradural or intramedullary metastasis, then once the neurons are destroyed, then there's no hope. For extradural compression, there is always hope. So, so you should always work hoping for the best. And in an extradural lesion, you should always try to decompress and take a chance.
This navigation system will bring that.
Probably because of radioactive iron.
When you have the compressive myelopathy in MD examination is like a full toss field. With the first case, you are passing his guy. Some of us, it happens with that. But none of us try to find out what happens after that when you have seen the past examination. What happened to the patient? And unfortunately, nothing much happens unless the patient gets to a good neurosurgical setup or orthopedic setup with interest in spine surgery, and then you get a good result and you have seen this. In last 1 year, we had about 10 patients of compressive myelopathy or radiculopathy were operated by neurosurgery and orthopedic surgery, and except 2 patients, all our patients have walked back home. The major issue in geriatric medicine is to get a lower limb function restored. It's one of the emerging indicators of poor outcome in after hospitalization or an illness is the lower limb function. So in all our effort to try to make the patient walk and get them as better as possible. And this also indicates the strength and our strength of aims in working as a team and 4 or 5 disciplines working together. It so happened, it's an anecdote that Dr. Kale was returning home after some of his weekly breech-laid eggs, and I crossed him on the path. So we just walked down about 10 steps and told Dr. Sahab, we told Dr. has कुछ करना पड़ेगा, and she was operated, and probably that 10 step of walking together and deciding what is to be done made a difference. Thank you, Dr. Kale, Dr. Chumbar, and Dr. Paul for taking the class. He lost all his age and probably never said I again. I request Dr. for the next piece.
So, good afternoon. We will now proceed to the next case, which I am sure will be interesting for all of you. And as you can see by the topic, so I will request Dr. Manjari to come and present the history as well as the EG findings.
So it is said that the flavor of life is emotions, and we've just had the previous case giving us an emotion of happiness. Well, happiness does spill into joy and then spills into laughter, and sadness does melt into tears at times. And this was the odd predicament of this father, who had till such a time that the baby started crying, thought he would enter this little child for a happy baby contest. So he was basically enjoying his fatherhood when the 6-month-old baby, as it presented to us, right from the day of 15 days of birth, would go into irrepressible giggles and kind of laughter and chuckling. So it was really a great fatherhood for him to enjoy till when he became about 3 months old, where along with that chuckling and laughter, which used to occur several times in a day, the child started crying and moving his limbs in odd manner. So that is when he thought that something is definitely wrong with my happy baby, and these episodes were pretty frequent. The laughter episodes were almost as much as 15 to 40 episodes per day, and the crying episodes were also several in a day, and the crying would last a little longer than the laughter episodes, so it becomes very distressful for the family before they brought them here. Now, of course, examination didn't reveal much except a healthy 6 to 7 month old baby, and the child had been, prior to coming to us, been tried on several anti-epileptics by the pediatricians. Had been given a combination of valproate, levetiracetam. So you can imagine a 6 to 7 month old baby receiving all these dreaded anticonvulsants for just laughing and crying, and was also on clobazam. So all these had failed to kind of control the episodes. But what is good to know is that the local physician there, a pediatrician, had kind of judged that these episodes had something to do with the brain. Well, he did present to the neurosurgery OPD because there was a lesion in the brain. But from the neurosurgery OPD, we got a call for confirming whether they were seizures. And as neurology teaches us, the first thing is localizing and trying to find out what the phenomenology is. So on the right hand of the panel is one seizure type, and on the left hand is the other. I hope the sound works. So so he would just keep doing this. You heard the chuckle followed by the mechanical sounds. And this would continue for some seconds to minutes. Chuckle followed by the mechanical sounds, and there would be some subtle deviation of the eyes, some subtle flexion of the body. So those were the pleasant episodes. He started out with these episodes. These didn't create so much of a problem till the father thought he was abnormal when he started having these latter episodes. So there he goes laughing. So that's the laughing seizures. And of course, these were the more distressing ones. And there he goes into a spasm, which lasts for several seconds. You can see the tonic spasm, followed by crying. And this would happen 40 times, 15 times in a day. So pretty much within a period of, 1 day, we could record as many seizures in this particular child. And the diagnosis was pretty clear. His baseline EEG, of course, he's a child who's only 6 years old, so we expect a dominant posterior rhythm of only about 3 hertz. 3 to 4 hertz was the dominant posterior rhythm. And then as he goes into the episodes, there is this high voltage slowing which comes in with frontal predominance, which progresses and spills over centrally. So bilateral frontal predominant spilling over posteriorly onto both sides, also seen centrally, sharp and slow in the episode. And this kind of slows down, so it evolves not only in amplitude but as well as evolves in frequency, increasing and then decreasing. So here we are seeing a decreasing frequency till it becomes more evanescent and kind of disappears. So this is the postictal. The other crying episode was, of course, again similar. It was not to any particular side, but it seemed to be much more widely distributed on the right hemisphere. The slowing, and then further slowing, increased in amplitude, then decrease in amplitude, further evolution, and then it goes away. So the role of the neurologist was done. Yes, these were not normal physiological emotional responses which the child was having, and these were definitely seizures. And so with no further investigations required, as per the International League Against Epilepsy Guidelines 2014, we referred the child back to the neurosurgeons.
So for the postgraduates, you can see that this is a very fascinating syndrome. You have a child who's 6 months old and is having continuous episodes of laughter. And in this case, of course, the funny thing was it was also combined with crying spells. So the patients actually came with MRI, and such a typical these typical symptoms along with MRI is very, very classical of one specific pathology. So I had unfortunately our radiology colleague could not come due to some But MRI doesn't take so much of expertise, or it doesn't require any special sequences in order for you to make a diagnosis. So if you see the routine MRI, it looks more or less normal, until you go down to the level of the optic chiasm where you see some kind of a mass. It's not enhancing with contrast. And now when we do the corneal sections, now you are able to make out the mass. So this is the third ventricle, these are the lateral ventricles, and over here you can see that there is a mass sitting right on the floor of the third ventricle, which is a hypothalamic area. It is more towards the left side, more eccentric towards the one side. So this is and when we did contrast MRI, it was non-enhancing. So this is very, very typically diagnostic of a condition called as hypothalamic hamartoma. And because it is present within the hypothalamic area, if you remember from your anatomy what exactly is hamartoma, it's not a tumor, but it's a mixture of all the components of neurological tissues, but it's present in a disarray. And because it was present in this, because it's kind of clustered together irregularly, it's firing, and it is causing seizures. As you can see, it's not enhancing with contrast. Now over here, there are many surgical options which I will show you later on. So there are open surgical options, there are endoscopic options, there are also some recent techniques of doing a laser ablation. But we decided to do a very recent technique, which is a robotic guided radio frequency ablation, because it's a very, very minimally invasive surgical technique. It just requires a couple of sutures on the brain. So now I will request Dr. Heri Subianto, our fellow in epilepsy surgery, to come and explain the surgical procedure.
Thank you, Professor. Actually, this young child. He is only 6 months old, so we prefer to choose the robotic guided radio frequency lesioning and disconnection of hypothalamic hamartoma, because, as Professor said, that this is very minimal invasive surgery that we can perform here in IMS. So this is first time robotic placement. We can see here that the robotic arms moving smoothly directly to the target area that we have planning before, as we can see here. And this is very different with we usually using Lexel stereotactic frame, where we have to correct the X, Y, Z manually, but this kind of robotic arms will move automatically to the targeted location. And then this we can see we made one put hole before SEG implantation, and this is also guided by the robotic arm. After final, we put stereo EEG intrahypothalamic hamartoma inside, and then we record the electrical activity within the hypothalamic hamartoma. We have measured also the length of the electrode, and then we put 10 electrodes inside the hypothalamic hamartoma. And this is the stereo EEG recording. You can see that there is a spike here along the grid of the stereo EEG. So we planning to perform 3 lesions according to this patient. Well, surgical planning with ROSA, and then 3 trajectory from one single port hole, and then MRI guided target localization using ROSA software also. We will reconstruct the axial, coronal, sagittal view, PET, air, reconstructed all to avoid vital structure along the lesion that we will make. The error in actual target localization was within 1 millimeter and was considered acceptable. The radio frequency was performed to create 5 millimeter spherical lesion within the hypothalamic hamartoma. So we have to make sure that we are not distracting other vital area. This is the Lexel radio frequency generator. We are using Lexel. They have many kinds of monopolar electrode. This is monopolar electrode. Start from 1 millimeter in diameter and 2 millimeter. We were using 2 millimeter in diameter. And then the surgery, patient was under general anesthesia, supine position, draping, sterile, C-shape incision on the skin, small craniotomy, only 2 times 3 centimeter, and then the ROSA moved to the selected target, and then measure the target distance from ROSA software, and then we insert the Lexel electrode and perform the coagulation at 70 degrees for 60 seconds. And we hope that we have made 5 millimeter spherical ablation. This is the surgical planning, video depicting the surgical planning. This is actually the first target. We are moving circular 5 mm, make sure that there is no vital structure around that. And then this is the second target also, circular 5 mm. We can see from coronal section, axial section also from the ROSA machine. And then post-operative, patient extubated in the OT, no neurological deficit, and then post-operative CT scan show also radiofrequency ablated disconnection exactly at the targeted planning that we have planned before. We can see here hypodense area in the targeted, and patient seizure free from 6 months until now, and it is 1B angle. And then
So this indeed was, the reason we undertook this. In fact, this is the first ever procedure in the world where we use a robotic device to perform an RF lesioning. And the reason we took up this is because of the very young age of the patient, which is just about 6 months. So obviously not amenable to any kind of an open craniotomy. So the mechanism of gelastic epilepsy is indeed very fascinating, and this would be of interest especially for the postgraduate students for medicine. So I will request Dr. Manjari to say a few words about gelastic or laughing epilepsy, and also about dacrystic or crying epilepsy.
So, as I introduced, there was no doubt about the diagnosis of this child having a mixed emotional epileptiform disorder of both gelastic and dacrystic variety, which is very rare to be found together. Usually either gelastic happens or dacrystic happens in isolation. Gelastic is basically, it comes from the Greek letter G los, which means to laugh or laughter. Now, the difference between this laughter and our spontaneous laughter is that it's very mechanical. So, as you could have heard in the video, the child was having very stuttered, stereotyped, mechanical chuckling and laughing. So, and usually it is a mirthless laughter. So the person or the child, of course this is a 6-month-old baby, but we have children as old as 18 years and 16 years and 15 years presenting with gelastic epilepsy, and they are laughing all the time, but they are never happy. So it's mirthless. It's a very miserable condition to have. So you're laughing, you're giggling, and you're actually not happy. You may be really very sad from the inside. So it's usually mirthless. The classical feature is that gelastic epilepsy is found in patients who have hypothalamic hamartomas. It's something very typical of that, and that's because of the propagation pathway. However, gelastic epilepsy has also been found in patients who have temporal lobe epilepsy, specifically basitemporal and lateral temporal, and also has been found in patients who have frontal lobe seizures. Now, the difference between those and the hypothalamic ones are that the lobar gelastic epilepsy is very often associated with a positive emotion. So the temporal gelastic will say that their laughter is mirthful. That is, that they feel happy, that when they are inappropriately laughing, they still feel happy inside. And of course, there are various functional studies which have been performed with the help of nuclear medicine, where PET and SPECT have shown high uptake of the anterior cingulate area and the temporal pole, as well as the hypothalamic lesions which is there. So what exactly is the propagation pathway for residents? It's important to remember that the hypothalamus is very closely connected. I mean, it's just at the junction of the forebrain and the hindbrain. So it's at a very appropriate junction where propagation happens downwards, and the hypothalamus then propagates, the fibers propagate downwards to the midbrain and then to the dorsal pons, and they trigger the cranial nerve nuclei. So that's why it's mirthless. It has no emotions attached to it. It has just a mechanical reflex contraction of the facial muscles, which is causing the laughter. And so it's mostly by downward propagation from the hypothalamus to the brainstem. And that is about the gelastic epilepsy. This child also had tonic spasms. As you could see, he was going into tonic spasms. So tonic spasms also appropriately occur with hypothalamic hamartomas, because the mechanism of tonic spasms is again a downward propagation from the hypothalamic area in this particular child, or from the thalamic area downwards. It goes via the corpus callosum to the other side, So for example, this child had a left hypothalamic hamartoma going to the right and then producing something like a decerebrate, decorticate posturing, which is the tonic posturing. So that's the mechanism for the tonic spasm in this child. This child also had quiriterian or diacrystic seizures, and these diacrystic seizures are more often associated with temporal lobe epilepsy, and actually they can actually have tears in the eyes. So people can have seizures with tears, and they may get mistaken as psychiatric patients, and very often these patients actually land up in the psychiatry ward before coming to the neurologist. The frontal diacrystic seizures are not associated with tears, but they are associated with unnatural crying or crocodile kind of phenomenon where there are no tears. And the hypothalamic are usually very brief. So that's as far as the pathways for the gelastic and the diacrystic component goes. So with this, I hand over again to the neurosurgeons.
So normally, the way we describe epileptogenic networks in the brain is, for instance, if you have a brain tumor. It is not the tumor itself which causes epilepsy, but it compresses the surrounding normal parenchyma, which becomes irritable and then produces an epileptogenic focus. Except for this condition. Hypothalamic hamartoma is actually a tissue which produces epilepsy. It contains tissues which are excitable and produces epilepsy. So that's the reason before actually doing an RF lesioning, we first passed an electrode and we were able to record spikes from this tumor, which is confirmatory that there are seizures being produced from this lesion itself. And as Dr. Manjari was saying, this is very, very, gelastic epilepsy is very, very typical of laughter mechanisms, and there could be different types of hypothalamic hamartomas. So this is type 1, then this is type 2, type 3, and type 4 is usually giant, and depending upon the types, which has been first classified by a French neurosurgeon called Delalande, who also described the endoscopic technique, we decide the surgical procedure. So we can easily perform RF lesioning for all the 3 types, and even 4th type, there are certain case reports in the literature where they have performed RF lesioning. Now these are all the various surgical approach options available. What needs to be understood is that this is a surgically remediable condition. So you cannot treat it medically. You can give a ton of drugs, the child is not going to improve. But if you do surgery, the success could be as high as 50 to 70%. So open microneurosurgical approach has been literally given off. So surgically we do not excise the lesion, because you have to understand that it is supplied by the same blood vessels which also supply to the normal hypothalamus. So you cannot excise this. In that way you are going to damage the blood vessels which are supplying to hypothalamus. So what you do is you do a disconnection, and that is what exactly we did with even RF lesioning. We produced an RF lesioning based disconnection. We didn't go on cauterizing the entire hamartoma as shown by Dr. Eri Subianto. We just disconnected at the point of entry or at the point of attachment of the hypothalamic hamartoma to rest of the hypothalamus. Endoscopic technique was the first minimally invasive technique which was introduced by Delalande in 2003. And gamma knife, even though is an option, is not so effective. More recently in US, they are performing laser ablation. We have done a couple of cases here during a workshop because this was donated, but I think this will be very difficult for the Indian population because these laser leads, they are disposable, whereas RF lesioning, which is performed by generator, can be done again and again, and it would just cost about 2,000 rupees. So it's extremely affordable by all our patient groups, and it's technically as effective as a laser lesioning, even though there may be some advantages of laser which I will show you. And this is the first case of robotic guided which has a high degree of accuracy ever in the world. So this is an example of a laser ablation which we have done during the workshop. So you can see it is MRI guided. It's an excellent device. You produce a laser ablation and there is a cooling effect around it. So as a result, this doesn't spread beyond. And this is a patient, just a single stitch, half an hour after surgery. And this is how you sculpt the hypothalamus in order to produce the lesion. But the issue is it comes with the disposable laser leads and the whole equipment is very expensive. It's around 5 CR. And every time you use a lead, it's about 5 crores. So the entire equipment is about 5 crores. And every time you use a laser lead, it costs about 1 lakh rupees for the patient. So this is now this is an example of a giant hypothalamic which we treated. As you can see, he's got precocious puberty, he's got pubic hair. Child was just about 3 years of age. And what we did is we did an endoscopic disconnection in this. This was almost 6 to 7 years ago. And you can see after surgery, the patient has almost completely transformed. He was having, he was looking almost like a man. He was having manly features. He was having acromegaly kind of face. But once surgery is over, he is completely quiet. And this is how we do. We introduce an endoscope, and you can see how it has been disconnected from the rest of the brain. But in order to perform this technique, it is still invasive. You have to go inside the brain. Whereas when we do, and you can see the hormones have normalized. But when similarly, we can do, earlier we were doing a transcallosal disconnection. We would go through the corpus callosum and then disconnect the hypothalamic hamartoma. But with the introduction of RF lesioning, which is robotic guided, it becomes very minimally invasive. The maximum time taken is only for planning, but the actual surgical time is just about half an hour, and patient is extubated immediately and can be discharged the next day, and it's extremely affordable by the majority of our patients. And as I've told, this is the first case what we have done in the world using a robotic device. So concluding, for the residents, please remember, you may not see this presentation, you may not see it again, especially for postgraduates. So if a patient has gelastic epilepsy or if he has dacrystic epilepsy, think of a hypothalamic hamartoma. That is a commonest pathology. And as Dr. Manjari says, it may also arise from temporal or frontal, but an hypothalamic hamartoma has to be excluded. This is a surgically remediable condition, extremely treatable by surgery. And here we have presented on how we have managed to treat this using RF lesioning, using a robotic guidance. So thank you very much. So finally, this is our slide about our Center of Excellence for Epilepsy. So we have a Professor P.N. Tandon lab which does advanced molecular and cellular neurobiology, which is in the 7th floor of Convergence Center. So any of the students who are interested to go and have a look at it, you're very welcome to go. Dr. Banerjee is here. And we are really doing advanced studies on the epileptogenic tissue. And this is a workshop which we're conducting from 1st to 3rd of September. And we also having a half-a-day course for medicine students as well as for PhD students on neurobiology of epilepsy, which is free of cost. It will of course have surgical cases. We will do live surgeries, cadaveric, that's for neurosurgeons. But for medicine postgraduates as well as for PhDs, there is a half-a-day neurobiology course. And if you are interested, you can attend this. So thank you very much. So any questions or comments?
Hello, Sarat, can you hear me? Sarat? Sarat, can you hear me?
Yes. Yeah, but trigeminal neuralgia, we can just insert.
No bilateral.
This is very minimally invasive. We just have to make a hole. Obviously, we cannot go through contaminated spaces like mouth. It's not, you cannot enter the brain. It's an extension of that. But instead of doing a large craniotomy, you're just using a small hole. It's just 2 or 3 sutures. It's disconnection. It's RF based disconnection of the lesion. Just disconnect. I will show you where exactly is the disconnection. That's why we say that the outcome is 50 to 70%. But the advantage of RF lesioning is we can repeat it. There is absolutely no harm. We can go on repeating it. So this is a post-op CT. So this is a hamartoma. This is a junction of hamartoma with the rest of the brain. And here you can see following the RF lesioning, it has become black. So once again, you can see this dark spot. So we have produced a 5 mm. We have to measure what is the passage between, or what is the pedicle between the hamartoma as well as the rest of the brain. And we just produce a lesion here. So this hamartoma you can see is live. But now this is not connected with the rest of the brain. So what we have done is, we just produce a disconnection, and that is what is advised, because if you go on cauterizing the entire hamartoma, it can cause thrombosis of the vessels, and these are very vital vessels which supply rest of the hypothalamus also. So all we are doing is we are just doing an RF based transaction, which is also a surgery, kind of a surgery. That's what exactly is done in surgery.
Sarat, how are you? Hello. Hello.
Good afternoon, sir.
Good afternoon. How are you?
I'm fine, sir.
You-
Very nice to hear your voice.
Did you not take biopsy?
No, sir, we are not taking biopsy.
Because it is a must. I suppose unless you take biopsy,
Yes,
you
sir.
will not know what is the disease.
Yes, sir. So,
Because
it's not
you know
possible.
that from Barros Institute, from Phoenix, they have the 170 cases of hamartoma. You know that probably.
We know that, sir.
From them, they have discussed about status gelasticus
Yes, yes. they
and
are,
the
sir.
success rate of various surgery,
Yes, sir.
including labor ablation, disconnection, surgery, and gamma knife.
Yes, sir.
So, what is
Sir.
the success rate?
Yes, sir.
60%, 70%?
It's around 60 to 70%, sir.
So
Now,
what
sir,
happened to those
yes, sir.
what happened to are you not giving anti-epileptic now?
Yes, sir. I'll answer them one by one, sir. So
Okay.
first is thank you so much, sir. Very nice hearing your voice. So the first question what Professor Mahapathar asked, which is a very pertinent question, that have you taken a biopsy? Now, when we are doing RF lesioning, even when we are doing stereo, that's one limitation that we cannot actually take a tissue. But ILE guidelines have clearly laid down the diagnostic criteria that when we see such an image, it is very much diagnostic of hamartoma. In addition, we are putting an electrode inside the lesion, which is now showing a spike activity from the lesion itself. Otherwise, normally when we put it into a tumor tissue, we don't see any spiking activity. So that in a way is confirmatory that this lesion is producing epilepsy and we are disconnecting it. So that is one thing. Now regarding anti-epileptic drugs, we have to understand that the role of surgery is not to make them drug free. The role of surgery is to make them seizure free. So anti-epileptics have to be continued. So they are like augmenting or they are like enhancing the role of surgery, and they have to be continued for at least 1 year. After which the neurologist will do an EEG and they will take a decision whether to taper or stop or not to stop.
No, the lesion is still there. That
Yeah. Yes, but it is not connected to rest of the brain. So that's why.
Does that answer you, Mahapathar? This is Dr. Ballai.
Thank you. Thank you, Sarath. I think they're finishing.
Thank you, sir. Thank you very much.
Thank you, sir. Good afternoon, sir.
Thank you.
Mahapathar is Dr. Ballai. Good afternoon. Good to hear your voice.
How are you? Hey.
अरे मैं तेरे पास आऊंगा भुवनेश्वर तो बुला वहाँ पे ठीक है ना we'll carry on there और कैसा है हाउस भुवनेश्वर how are you doing good very good to hear your voice यार मजा आ गया चल हर बार ही रहा कर ट्यूसडे को okay all the best bye